My name, of course, is Abby. I work for the Health System Partnership team at Maple. And basically what that means is I work with all of our different public sector partners. So Maple is a company that offers private virtual care. I work on our public sector section of that company. So what I do on a day-to-day, it's a little bit of everything. It's always different every single day. But to boil it down simply, I would say half my amount of time is spent just managing our day-to-day operations of a few of our largest programs that we run. The other half is spent strategizing and working with our different partners to learn what other opportunities might be a good fit for us to work together to increase access to care for everyone. In the relation of this context, and I know we're talking about, how can virtual care help a lot of these different primary care issues that we see, one of the programs that I'll speak to that a few of you might have even heard of or maybe even experienced yourself in this room would be our partnership program, Virtual Care Nest with Nova Scotia Health. So that's a program that's available to any patient in the province who doesn't have a primary care provider and allows those patients to access on-demand virtual care when the need arises. So that's just a great way of illustrating exactly how we're using virtual care to deliver care to a wider audience. And what I think is really powerful about the work we do, especially with that program, is that it allows providers, physicians, nurse practitioners from all across the province to service patients in rural, remote areas. So really you're kind of leveling that playing field, giving everyone the same access, even if you live in a super remote area of the province. So that's one of the examples of the programs I work on. We have a few different programs that are similar in nature to that, where we're working with the unattached population to give them better care options. But we also have a few different programs that we do as well. We have a few virtual emergency department programs that either treat patients from home so they don't have to go to the emergency, or they identify them when they're in the emergency department to say, hey, you're someone that's probably going to wait 6 hours. Why don't we put you through this virtual care route so you can be seen faster, you're freeing up the capacity for the folks that are working in the emergency department, and really you're filtering patients to go through a more appropriate form of care that they would need. So that's another example. We do a lot of different programs that are based around that factor of, on demand, requesting care when you need it, different communities that'll be able to access it. In New Brunswick, we're available for everyone in the province, not just those without a primary care provider. So it's a lot of different interesting stuff like that. And then it's always, how can we make this better? How can we see more patients? How can we make things easier for the providers that are seeing these patients virtually? So it really is such a large amount of things that we're doing on a day-to-day basis, but really exciting stuff.
Okay, thank you for that.
Awesome. Thanks so much for having me, guys. I'm really excited about this. I've been following this work that's happened in other provinces, and I'm so excited to hear what Nova Scotians think, because I think this is really going to influence people like me at a leadership level in the health authority to really think about how we can do things differently. So thank you for your time. Can't wait to see what you guys come up with. So I'm an internal medicine specialist. It's kind of a contradiction. I'm a general internal medicine specialist. Get around that one. So for those of you who are TV fans, House is a general internal medicine doctor, but we do not do brain surgery. That's an exaggeration. But we're sort of the front door to the specialty-based healthcare system. So if your family doctor sees you and needs additional support of where to go next, often internal medicine is the first stop you'll have unless you need a surgery or that sort of thing. And when you come into the doors of the emergency department, if you need to be admitted to hospital, often it's my service, internal medicine, that you're seeing. So that's part of my job, and I'll say from a clinical perspective, my very strong belief is that primary care is the most important part of the healthcare system, and that everybody else in the system is not able to do their job well if we don't have a really well supported primary healthcare system. And I live this every day in my internal medicine practice, that a lot of what I do would be totally unnecessary if people in this province had better access to primary care. So I think we're really feeling the crunch of lack of access to primary care in terms of the demand on specialty services. And we have long wait times. In my own clinic now, it's over a year for really important health conditions, so totally unacceptable lack of access. And again, that's because our demands are really much higher because of that lack of access to primary care. People are coming later and sicker because they didn't have access to that preventative primary care. My day job now, though, is not really as a practicing doctor. That's part of my day job, but a small part. So my main day job now is as the Chief Medical Information Officer for the province. So my job is basically to shepherd, from a physician's perspective, new technologies to support care. So you may have heard of the big project that I'm co-leading right now, which is called One Person, One Record, which is an initiative to try to bring a single clinical information system, meaning a digital health record, to the acute care space of this province. So anytime you go into hospital anywhere in Nova Scotia, we'd be working from the same record. That's really different from today. If I don't know if there's any K-Bretners in the room, but not uncommon that we get transfers, for example, from Sydney because people need specialized care, and we have no idea what happened to you except the pieces of paper that come photocopied with you when you take the ambulance to Halifax. So this future system is you're going to have a single record, and there's lots of other modern elements that are going to come with this proposed One Person, One Record system. One of the ones I'm most excited about is, as a patient, you're going to have much enhanced visibility to your own health information. So you're going to have access to your laboratory results and your x-ray results and your notes from people like me in clinics. So that's a big component of that product as well. It's a little bit interesting because primary care, which is what we're here to talk about today, isn't technically in scope for One Person, One Record. So the environment right now in Nova Scotia is that most family doctors are independent practitioners, like they own and operate their own business. So it's actually up to them what health system they use. Almost all primary care providers in this province use either Med Access, which is a TELUS EMR product, or a Curo, which is from a company called QHR. Some people will be on One Person, One Record, and that's family doctors who work in clinics that are owned and operated by the health authority, so Nova Scotia Health. That's a small minority of family doctors, but it is growing. I know you're going to meet Maria Alexiadis tomorrow, who's the head of primary care, and we were just having the conversation this past week, and she told me a lot of new family doctors are really wanting to work in that kind of model where they don't have to be a business owner, because spoiler alert, I didn't learn very much about running a business in medical school. So I think increasingly there's this push towards people wanting to be more in an employee structure, and those are the kinds of clinics that we're looking to. But I will tell you, don't tell the other people I work with, because it's a bit of a secret. I know this is being recorded, but in a future iteration, we're definitely starting to talk about how do we get primary care in the fold, because to have a digital record system that doesn't include primary care is pretty chaotic. That's the most important part of care. So we're definitely have an eye to that, but these big infrastructure projects, we have to kind of bite one chunk at a time. So that's long-term vision, but first step is the hospital. Is there a question there?
I have a question. Why aren't doctors signing on to it? Is it cost prohibitive? Is it not organized? What is the issue where a primary business would use the majority system?
Yeah, so we haven't actually given them the option, is the short answer. So we haven't implemented the system yet, the One Person, One Record system. We're sort of configuring the system now, and our first big go live, meaning a hospital adopting it, will be in 2025. So that would be the first opportunity to sign on. It's a great question. So we're actively exploring that now. My perspective is it probably wouldn't be any more, potentially even less than what they're paying right now for the other EMR systems. But the reasons why they weren't in scope are a little more complex. There's privacy implications, data stewardship. There's some things embedded in our legislation in Nova Scotia that sort of keep primary care in charge of their own record system. And if they signed on to this One Person, One Record, everyone in the system would be able to see their information. So it is a significant shift of how things work now. It's not an impossibility, and I commit to you that we're absolutely working on it right now. We're scoping that. I will say part of the recommendations that you will come up with, I will absolutely advertise that. And I say this to primary care doctors, I'm a specialist working in a hospital-based system. This system is going to work really well for me, but I need to hear from patients and primary care providers about what would work for them in their context. And we're starting to get that feedback. So, it's a large conversation. I don't want to oversimplify what it would take to do that, but we definitely have an eye to that. When the proposal for this project went through 7 years ago originally, the scope didn't include primary care, partly because those doctors said, I own my own business, I want to own and operate my own system. I'm the steward of my practice's data. I'd say there's been a big culture shift in the time since the project was initially scoped versus where we're at today. So we're having to adapt now to that reality.
Just a follow-up question on that. And you want to do?
No, because I do want
Cheryl
Cheryl to be able to share, but
Yeah.
but in fairness to, so
Yeah.
ask your question, but then folks hold it for 2 seconds so Cheryl can speak a little bit, and then open season, I promise. Go ahead.
Oh, just as a comparison, it's not at the same level of information, but pharmacies in the province, if wanted to get paid by MSI, have had to bill electronically and share records since 1991, and they're all independent owners, or they could be a chain, you know what I mean? They're commercial entities, and they have different softwares. So, like, I'm just curious why there can't be different EMRs that still talk to a same standard, and paying physicians could be the stick or carrot, whichever way you want to look at that to get them on.
Yeah, that's an awesome question. So there's lots of other work around interoperability between technology systems. So what I'll share with you is that even in systems like pharmacy, the information sharing across silos is not great anywhere in the country. This has been a problem that Canada Health Infoway, which is our national body looking at health information exchange, has been working on for decades, and it's interoperability. And a lot of it is that traditionally technology companies haven't been mandated to have specific data standards. So there's a big move now, even in Nova Scotia, we don't have an established data standard. So Maple isn't held right now by Nova Scotia Health to a specific standard that they have to comply with. So we're looking at how do we implement those standards so all of the private companies we're working with in the province, they have to have the ability to speak to each other. So that's another piece of work, but we did recognize that independent of interoperability, there's a lot of benefit to having a single record system in terms of making sure that there's not information that flows through the cracks, but also in terms of just the efficiency of your work. I'll tell you, like in my average day in clinic, I'd say easily 50% of the time I spend is on tasks that could be automated. So when we're talking about a crisis of personnel, why would we be trying to spend hundreds of thousands of dollars creating new doctors and recruiting new doctors when we can just make the ones we have work more efficiently? So, I think in different settings, that's a different statistic. I think my practice is particularly inefficient. So there's a lot of potential gains to be made with automation. That might not be the same case in other more efficient practices. But I do think it's a really important conversation too. It's not just about data sharing, but it's also about supporting how our providers deliver care. Okay, go for it, Cheryl.
Hi, everyone. Thanks for having me. So I'm a family doctor and addictions physician based in Ontario. I also do research. About 50% of my time is devoted to research. I look at health systems, new technologies, and commercial interests, so anything that kind of falls at that intersection. So I'll bring some of that into the presentation that I'm going to give today. I'm going to start sharing my screen. Everyone see that?
Yeah.
Okay, great. So as mentioned, I'm from Ontario, and as most of you or some of you may know, Ontario took a different approach to walk-in type virtual care than Nova Scotia did. So this is virtual care that is largely offered by corporations, companies, through a proprietary software platform like a website or an app directly to patients. And generally does not include in-person care or access to ongoing care. So Ontario recently made some cuts. They decreased the fees that they were paying physicians who were providing this type of virtual care. And their goal, what they wanted to do with this, was incentivize physicians and nurse practitioners to instead practice in comprehensive models of care where virtual care was integrated into ongoing care. Now, there's a problem with this. In Ontario, like all provinces and territories in Canada, a lot of people don't have a primary care provider. And even if all these physicians and nurse practitioners shifted to providing comprehensive care, there would probably still be a large proportion of the population that doesn't have access to a primary care provider. And now they also don't have virtual care, so their only option really is the emergency department or walk-in clinics. So Nova Scotia, as you all know, took the opposite approach and contracted with a for-profit company to offer virtual care to unattached patients. And, they're not able to offer them comprehensive care, but at least, they're offering these people access to virtual care. But there's problems with this as well. So the limitations of the walk-in style virtual care, it doesn't provide that comprehensive longitudinal care where people have care by the same provider, the same team over time, where they get screening, where they get in-person visits, management of their chronic health conditions. And the reason this matters is this is the primary care that really makes a difference to health outcomes. And it increases patient satisfaction, and it also saves money. So when patients have access to high quality primary care, they have fewer hospital visits or fewer emergency department visits and lower rates of hospitalization. And with the expansion of the walk-in direct-to-patient or direct-to-consumer virtual care, you could also see an erosion of existing comprehensive care. And that's because there's a fixed pool of physicians and nurse practitioners. So if they're working in virtual care, walk-in episodic care, then they're not providing comprehensive care. There also are risks to patient privacy through the expansion of walk-in virtual care when it's run by corporations or companies. This is where my research comes in. We received a grant from the Office of the Privacy Commissioner of Canada to examine the data handling practices of commercial virtual care platforms across Canada. Now, these platforms collect a lot of different kinds of data from user data like IP addresses, device identifiers, sign up and registration information, so when someone first accesses a platform, like names and email addresses. And interestingly, we looked at privacy policies and interviewed employees of these companies. Companies don't define that sign-up information as personal health information. They define it as personal information. So these data are used, to improve services, but they're also used for marketing reasons, and they're also often shared within the larger corporation or sometimes with third parties, especially user data shared like with Google and Facebook. The data that they do define as personal health information, which of course is personal health information, the information shared with physicians and nurse practitioners, this is often de-identified and then also, shared externally, used for other purposes. It's very difficult for patients to opt out of these data uses. In some cases, the only option really is not to use the platform. So there's concerns around privacy with that. There's also concerns about problematic data uses. So we also found through our interviews that some platforms were partnering with the pharmaceutical industry, and the pharmaceutical industry or companies essentially were sponsoring these platforms to increase the uptake of vaccines or drugs. So they were adjusting patient care pathways, how frequently they sent out reminders to patients to get a vaccine or a drug, the timing of visits with a physician, timing of lab tests, and then looking for the pharmaceutical company to tell them, oh, this increased uptake, oh, maybe we can tweak this, and then continually adjusting these patient care pathways. And participants in the study, said this is appropriate behavior, this is to be expected. These are companies in the private sector, they need to make money, but they were concerned about pharmaceutical industry influence over care. The other thing that might happen with the proliferation of commercial virtual care platforms is data silos. Companies view data as a commercial asset and something that they'd be reluctant to share unless it provided an advantage, a business advantage. So we're stuck between a rock and a hard place. So on one hand, we have more comprehensive care, perhaps like in Ontario, but then this segment of the population that doesn't have access to comprehensive care and doesn't have access to virtual care. Their only recourse, visit the emergency department or go to a walk-in clinic. Or we have perhaps like in Nova Scotia, maybe fewer people with comprehensive care, but then all of those people who don't have access to comprehensive care have access to virtual care with all the risks and the problems that I described. So we can debate these, but what I'd really like to do is present a vision, a way that we could do it differently, a way that everyone could have it all. So across Canada, everybody could have, access to comprehensive primary care, access to virtual care, and rapid access to care when they need it. So whether that's a same-day appointment or, urgent care after hours, all of this. And it's not just a vision, it actually exists. There's a primary care system, the Netherlands, one of the highest rated in the world, and this essentially is what they have achieved. So my brother and sister live there, and I talked to my sister about her experiences with care there, with virtual care there. And like 99% of the population, she has a general practitioner. Their office has a website that she can access. She can renew her medications there. She can communicate with her provider through secure messaging. She can book appointments. She also can get same-day urgent appointments if she needs it with her primary care provider or someone else on the team, like 77% of people who live in the Netherlands. And then after hours, everybody, 100% of the people in every kind of catchment area have access to after-hours urgent care. And this is urgent care. It's a clinic essentially, but it's run by all the family doctors who are in a particular catchment area. And they're all obligated to work shifts in this after-hours center, which is attached to the hospital. And they have a certain number of hours they have to work there per year. It's funded and supported by the insurer through the hospital. So the hospital provides the triage nurse, and it's open from 5 o'clock in the evening to 8 o'clock the next morning. And what happens if you have a health concern, you can show up there, but what most people do is they call. And then the triage nurse decides, is this something that can wait till you see your family doctor the next day? Is this something that we can provide virtual care for, on the phone or video, or should you come and see us? Or get this, have a home visit. So they usually have two physicians working there. One is working at the urgent care center and the other one's driving around doing the home visits. And it's all like decided by the triage nurse and the physicians working together how to provide the best care for people. So how do we get there? Well, we need to change a few things. The first thing we need is a primary care system. So we need some kind of group of primary care providers working in some kind of cooperative group, a nonprofit organization that's responsible for a region and it is accountable to some kind of health authority. And they need to, ensure that everybody has a family doctor and nurse practitioner, everyone can get the after-hours care as well as the integrated virtual care. And how do we do this? So we need to increase capacity and we need the resources. So one thing is shifting funds to primary care. I don't think we necessarily have to expand our healthcare budget, but I think we do need to shift it. Compared to other countries in the OECD, Canada spends a smaller percentage of its budget on primary care relative to specialized care. So that's one thing we could do is start to shift some of those funds to primary care. And you know what? We'll likely see cost savings. If this is translated into high quality primary care, then we're going to have fewer people in the emergency department and admitted to hospital. We need to increase capacity. We probably need more family doctors and nurse practitioners. Again, we have lower per capita than the average, and given our geography, we probably need to at least have the same or higher. But there are other things that we could do as well. One is more team-based care. A lot of physicians and nurse practitioners report that they're working on things that aren't patient care related that other people in a team could do. And this could free up more time. Also paperwork and administration. I mean, this has changed so much in the 15 years that I've been in practice. I used to come into clinic, maybe 15 minutes early, stay maybe a half hour late, and I'd be done all my paperwork and whatever else had to be done. And now for every day in clinic, it's a half day at least of extra work. And this is a complicated issue, and there are people that are working on it, so I won't get into it, but this is something that needs to be addressed as well. And then compensation and incentives. As you may know, there's a lot of empty primary care spots in residency. It's not an attractive specialty for a number of reasons. The administrative burden, downloading of tasks from specialists to family doctors, and the complexity of care. And it's not well paid. It's the lowest paid specialty. Now we need funds and support for the after-hours clinic. Like in the Dutch system, this is supported by the insurers that they, supply this clinic. They pay the physicians to work there. They have a nurse, a triage nurse there as well. And we need to support integrated virtual care. So this is really where the technologies from the private sector come in. Whether it's, telephone, 75% of my virtual care is on the phone, video, electronic medical record systems, all of those things. They need to be integrated into ongoing care. They need to be interoperable, especially for rural and remote regions. Virtual care is incredibly important. And it likely needs to be legislated. It's complex to make systems interoperable. It's going to take time and effort, and there's incentives for companies to hold on to their data and not to share it. So it probably is going to require legislation like they have in the US that mandates things have to be interoperable. And also we need better legislation around privacy to protect your health data, your sign-up registration information, but also your de-identified health data, and make sure that it's being used to, for reasons that patients want it to be used, to improve the health system, for research and not for marketing and other reasons. And I really believe that these systems need to be integrated into primary care, not as standalone systems that deliver care themselves. Studies consistently show that when corporations deliver care, costs go up and quality goes down. So we need some kind of primary care system that can incorporate these technologies and make sure that they work appropriately. So summary, primary care system with accountability, we need the capacity and the resources, and then integrate and regulate those technologies.
Thank you, Cheryl. Yeah, okay, thank you for that. So Ashley, Abby, Cheryl, thank you. Okay, so can we maybe, I'll open up for questions from the group in 2 seconds, I promise. But just picking up on what Cheryl shared through her presentation, I'd love to give each of you just a chance to speak quickly to some of the points. Like Abby, if you want to speak to the commercial interest piece, like the role of, if you want to talk a bit about that, and then Ashley, maybe that example of the Netherlands, like, and think through like Nova Scotia, like kind of where the problems are going from your perspectives, and then open season.
Yeah, sounds good. Yeah. All right, so happy to address a few of the points that were made. I think there's an incredibly large conversation to be had about how corporations work with the public healthcare system. I think there's no doubt about that, and agree with all of the ideas that were shared, and the optimal state would be to have everyone with a healthcare team that they're able to see, that they can access after hours and anytime that they need, and all we need to do is recruit more personnel to come and help us make that happen, which is great. I think that's so important. And I would less see those as two totally different things that need to be working separately, but more so things that need to be working together. So we should be making those changes and trying our best to hire more staff and bring folks to the Maritime and bring them to these rural areas. However, I think in practice, it doesn't always work out just that way. So what I would rather see is, how can we come in with a company like Maple, and how can we support the work that's already being done in the public healthcare space, and how can we leverage resources across the province instead of having them static in one area, and how can we supplement instead of take away, I think is what I'm really interested in. And then with my role in particular, on the Health System Partnerships team, we call ourselves the Partnerships team because that's exactly how we see ourselves. It's less of us coming in and being this scary vendor, and more of us working directly with these folks in government, in hospitals, in primary health care to say, what works for you? What's your pain point? Where are the opportunities, and how can we work together to make something that's really innovative, really exciting, and tackling the problems in a way that they've never been done before?
Thanks so much. Thanks for that presentation, Cheryl. I loved hearing that summary. A lot of that really resonates with me in terms of the Nova Scotia context. So I'm going to speak specifically to data silos. And this is sort of independent of any company specifically. Unfortunately, in Nova Scotia, the reality is we haven't invested in the core technology infrastructure necessary to support information sharing. So for example, when an innovation comes forward like OurCare Nova Scotia, or for example, the pharmacy primary healthcare teams, we actually don't have an option to provide that would allow that information to be shared. So we operate right now in Nova Scotia. Obviously, this is what we're trying to address with one person, one record. But we operate in a system where we scan documents. We can't search that system. So the only way that I could get the record from Virtual Care Nova Scotia would be that for them to print off a paper summary, to put a barcoded sticker on it, and to send it to be scanned, which has a backlog of about 6 weeks. So you can imagine that if you're an unattached patient today who has, an urgent medical issue that you can't see a primary care provider and you access Virtual Care Nova Scotia and you see a physician, you have a care plan, that would be documented in the Virtual Care Nova Scotia system. Nobody else in the system can see that information. So if you end up coming to my clinic in internal medicine, or you unfortunately get sicker and you have to go to the emergency department next week, that information isn't available. So you can anticipate all the challenges that arise from that. And I'll give you another example. Virtual Care Nova Scotia often refers people to my specialty because a lot of people who have been unattached for many years have a lot of complex chronic medical conditions. So it's not an uncommon circumstance where I get a referral for an issue, and when I pull up the hospital-based record, I can see that that patient's actually already seen a specialist or already has a care plan. But the doctor who's working in the Maple platform doesn't have visibility to that record system. So there's so much inefficiency that comes from data silos. I don't think that's inherent to any specific company or model. It really speaks more to the fact that we haven't adequately invested in mandatory interoperability standards. So Sheryl alluded to in the US, it's actually now legislated that you cannot function as a technology company unless you support interoperability. They have legislated data standards, so they have to use the same data language so that systems can speak to each other. They can't own data as a proprietary output. They have to share it for the purpose of information sharing when it's relevant to care. So these are things that actually need to be a political movement. Like, we need to advocate, because that's not really dependent on a technology company or even the health system. These are legislated issues that really need to come from a political voice. So these are the kinds of conversations we need to be having with our elected representatives to talk about why this is important. And I think we also have to advocate as a system, and I don't think anyone working in Virtual Care Nova Scotia likes that there's a data silo. It's just sort of an unfortunate reality of the fact that we don't have that infrastructure in present state. So we also have to think about, as we're building new systems like one person, one record, how can we make that accessible to community-based pharmacies? How can we give visibility to the Virtual Care Nova Scotia team so that when information is important to influence care, we all have access to that as a care team? So definitely it was resonating with me. We have significant issues with data silos that we're trying to fix for, but this new system is not going to fix that entirely, because there's still going to be community-based privately owned pharmacies. There's still going to be innovative virtual care delivery models. There's still going to be independent walk-in clinics. So we need to think about, how do we move towards a future where we're expecting and mandating that information is shared for the purposes of clinical care?
With mobility today, though, how do you deal with the interprovincial issues of silos? I mean, we don't all use the same system, so it becomes an even bigger problem and harder to solve.
Yeah, that's an amazing question. So, there is associated work at that federal level. Like I talked about, Canada Health Infoway is very invested in interoperability, and this has been a big conversation point for the premiers when they've met. The problem is that we all have our own little contracts. So, even this one person, one record program that we're doing in Nova Scotia, Newfoundland's doing a similar program, different vendor. New Brunswick is doing a similar program, different vendor. That would matter less if those vendors were all held to the same data standards and interoperability expectations, but in current state that doesn't happen. And it's very provincially based. So like other elements of the healthcare system, which I'm sure you guys have talked about, this whole construct of how healthcare is delivered provincially doesn't always reflect the realities of how the country lives today. I see many patients who have a cottage in New Brunswick, or they have grandchildren in Ontario, so they spend a proportion of the year there. So, we have these artificial boundaries that don't necessarily reflect the reality of an increasingly mobile world. So that's a great point. I don't have a fix for that one, unfortunately.